I thought I might talk today about something that I see a lot of in the acute hospital setting, but is something that can be managed really well at a GP level, and that's the management of diabetic foot disease. As you know, type 2 diabetes is becoming increasingly common in our community. There's a prevalence rate of about 7% across the population. So across Australia, we're seeing numbers close to 2 million people being diagnosed or having been diagnosed with diabetes. And of these, about 15% of people will develop a diabetic foot ulcer or a diabetic foot infection at some point during their life. That is an enormous burden on the healthcare system, around 260,000 people who will likely require a hospital admission of some kind for that problem. Foot ulceration is the leading cause of hospitalisation of people with type 2 diabetes. The problem is that when you get a diabetic foot infection, if it's uncontrolled or unmanaged, a significant number of people will go on to have a leg amputated, and if you have one leg amputated, there's a 50% lifetime chance that the other leg will go on to be amputated. More so, after 5 years, the mortality for the patient for all causes is up to 80%. So we're talking about a cohort of people with really intensive medical needs. For this reason, primary prevention strategies, keeping these people out of hospital, is really cost effective, not just great for the patient, but great for the community as a whole. So what do primary prevention strategies involve? Primary care level reviews, intensive glycemic control, optimal foot care with regular review by a podiatrist, and early recognition of problems that may arise. So who are the people that we should be looking for to determine whether or not they're at risk of diabetic foot infection or diabetic foot ulceration? And the answer is, it's every diabetic. But of that enormous group of people, who are the people who are at most risk? Those who've had previous ulceration or previous amputation. People who complain of symptoms of peripheral neuropathy, that typical burning at night time or numbness in the feet. Those with known peripheral vascular disease. People who've got foot deformity, the clawed toes, the misshapen arch, and of course Indigenous patients represent a special group of people who are at particularly high risk of diabetic foot infection. When I'm reviewing people with diabetes and I'm worried about diabetic foot ulceration, I try to stratify them into risk categories: low, intermediate or high risk. Who's low risk? Low risk people are people with no major risk factors, no neuropathy, no peripheral vascular disease, no history of ulceration. They can be reviewed once a year for a general checkup. People who are at intermediate risk are people with one risk factor. So maybe they've got known peripheral vascular disease or neuropathy, but they've not got any previous history of ulceration. Those people should be reviewed every 3 to 6 months and linked in with a podiatrist, maybe through a care plan. It's the high-risk people that we really need to focus on. Those are the people with 2 or more risk factors. Perhaps they've previously had an amputation of a toe. Perhaps they've previously had an ulcer that's healed over with careful management. Those are the people who should have their feet reviewed at every clinical encounter, and those are the people who should be referred for close care through a podiatrist. So why do people with diabetes get foot ulceration? Why are they so prone to developing these particular problems? The pathway to diabetic foot infection is complex and it involves a number of different factors. Diabetic neuropathy, which we've touched on, peripheral vascular disease, but also people, as you know, with diabetes have got impaired immunity, they've often got impaired vision and they can't get down and see what's going on with their feet. They're often elderly, immobile, inflexible, they can't get down to trim their own toenails or inspect between their toes every day. And there's often an element of renal impairment as well, which also impairs immunity. When it comes to diabetic neuropathy, all of the modalities are important in the pathogenesis of diabetic foot infection. So that's the sensory component, the motor component, and the autonomic component. When it comes to the sensory component, the reduction in sensation, the reduction in the ability to be able to feel what's going on with your feet makes you prone to unrecognised trauma. When it comes to motor neuropathy, it tends to be the small fibres that get affected first. So you get wasting of the small muscles of the feet, the toes get clawed and you get this pressure redistribution in the feet, leading to areas of callus and leading to areas of trauma. And then the last component, which is autonomic neuropathy, is really important because that leads to cracks in the skin, dryness of the skin, and those cracks allow bugs to get in, and that's often how these infections start. So it's the interplay between the reduction in sensation, the changes in the shape of the feet, and the bugs getting in because of the dry skin. All of those things lead to the development of diabetic foot infection. As a vascular surgeon, one of the reasons why I get involved with these patients is because they often have peripheral vascular disease. In fact, most people with diabetes, if you leave them for long enough, will develop some form of blockage of the arteries, typically in the calf. It's a really different pattern to what you get in people who are the typical smokers or people who've had untreated high cholesterol for many years. People with diabetes tend to get blockages in the arteries or peripheral vascular disease below the level of the knee joint, typically tibial disease. People who are smokers tend to get blockages in the major arteries, the iliacs and the femoropopliteal segment. And the management of these two groups of patients is extremely different. Because the blockages in diabetics tend to be below the knee, these people don't claudicate. So if you've got a blockage in the femoral artery, you may get pain when you walk after a couple of 100 metres. If you've got a blockage in the calf artery, you probably won't notice it at all. And that's typically what happens with diabetics. They present with an ulcer, having got pretty bad tibial artery disease with no history of claudication or no known history of arterial problems whatsoever until their very first presentation. If I was going to try and give one take-home message from this presentation, it would be that a foot ulcer in a diabetic is serious and it needs to be managed immediately. That's the take-home message. When should you refer someone who's got a diabetic foot infection then? When should you send them on to a multidisciplinary team for review? Any deep ulcer that extends into tendon or bone. Any ulcer that, despite your careful management, does not seem to be improving within a 4-week period. Any ulcer that's present when there are no foot pulses that you can determine. Anyone who's got significant associated surrounding infection or cellulitis, and anyone who's got a lot of swelling in the foot and you suspect that there may be some kind of underlying bony problem. In those people, I recommend they be referred directly to the emergency department, or we now have a high-risk foot service at Lismore Base Hospital which is able to review people quite quickly.